occurred in Duke within the last couple of months, so they're all real. Not all of them are exactly by the guidelines clean, so they're all real. And then we'll talk through the management decisions and why we did what we did. So just to introduce myself again, I'm Rob. I'm one of the EPs at Duke. Let's see. Oh, I'm trying to click that somewhere. Right, I'm a faculty speaker for Medtronic. These are my disclosures this time, not Andrew's, so they're not numerous long. So let's look at case one here. So this is a 57-year-old guy, presents for initial evaluation, having recently moved to the area. Has diabetes and hypertension, both well controlled, and also has heart failure. His heart failure was diagnosed about 12 months prior. He feels as though he has marked limitation in his physical activity. He is comfortable at rest, but less than ordinary activity causes fatigue. That's the almost verbatim definition of New York Heart Association Class 3 from the ACC. His heart catheterization showed insignificant coronary disease. And an echo during his hospitalization about 2 months ago showed an ejection fraction of 25%, unchanged to his original diagnosis. Current medications include beta blockers and lisinopril as well as diuretic. Here's his EKG. So on EKG, things that I'm looking at here, I recognize that the patient is in fact in sinus rhythm, which is a good thing for him, as well as a conduction delay. It appears to be left bundle in pattern, and if you count the little boxes, I hear about 180 milliseconds. So based on that information, how would you guys proceed from here? Go ahead.
How long did you say?
It's a 12-month diagnosis of heart failure with a low ejection fraction, 25%. He's had a negative ischemic evaluation with the cardiac catheterization. He's been on goal-directed medical therapy, has New York Heart Association Class 3 symptoms. This, like I said, has been going on about 12 months. Last echo showed unchanged EF. IV, would you go CRT-P?
Yeah, sorry.
Or CRT-E? So he's got a couple things here. So looking just from the CRT standpoint, I know the type of CRT, but you also as the, of course you can send them to me and I can help them decide what's going to happen. But it's nice for you guys to think about this too. While we're thinking about CRT in this patient, we also have to think about another life-saving entity, and that being a defibrillator as well. So I think this patient would be set up for a CRT-D. And that's in fact what he got. You can see his chest X-ray here. Again, just to go over the chest X-rays, here's your device, your defibrillator, somewhat larger than the pacemaker. Here is the defibrillator beam itself in the right ventricle, a right atrial lead. He is in sinus rhythm. So we want to make sure that we sense the atrium as well. And here's his quadripolar coronary sinus lead. So here's the lateral picture. I've outlined the lateral curve of the myocardium here. Here you can see the coronary sinus lead and then the right ventricular lead. So some pretty good separation between those two leads there. Hopefully benefit from coronary sinus pacing. So why did we do this? So here's the updated guidelines for CRT. And here, he fits under a class 1 indication for CRT-D. Here it is blown up. So a CRT-D indication has an EF less than or equal to 35%. Sinus rhythm, which our patient was. Left bundle branch block. QRS duration, we said it was 180, so greater than 150 milliseconds. New York Heart Association Class 3. Remember we said he had no symptoms at rest, but less than ordinary activity brought about exertional issues. And he is, this gets a little hairy, but he's certainly not a class 4, and he's on goal-directed medical therapy. So this is very strong level of evidence today for 3 and 4 patients. So that's nice. That is a class 1 indication, and it's perfectly acceptable to say, why did you do this? Well, smarter people than myself said I should do this, and that's fine. But how did they come up with this? Well, they came up with this based on some relatively recent trials, but not terribly recent. Here we see the companion study. What the companion study looked at is they had about 1,500 patients. They randomized these patients who fit those criteria to pharmacotherapy only, a CRT-P, or a CRT-D. And what they found is that CRT, cardiac resynchronization therapy, improved survival in all patients. When you add it to a defibrillator improves survival even further over pharmacotherapy alone. So that's one of the studies that they used to come up with that recommendation. Here's another study. This is the CRT study. This was a European study and actually looked at patients comparing medical therapy alone to only CRT-P, so only pacers, so cardiac resynchronization therapy with a pacer without a defibrillator. And in that study, they also showed a significant survival and/or hospitalization benefit. And here is mated CRT, which looked at the comparison, or compared defibrillator only to patients receiving a CRT-D device, and again, showed an improvement over ICD alone. So this patient, again, class 1 indication, this guy's good to go, should probably get a CRT-D device. Let's look at case number 2 here. It says 64-year-old guy, non-ischemic cardiomyopathy, EF 15%. He's on optimal medical treatment, however, he's experienced a significant functional decline. And this has gone on. This is an even worse recently since he had his ICD fixed a few months ago. Review of his medication, so he's on beta blockers, inhibitors, and diuretics. And recent echo post procedure shows an EF continuing to be low at approximately 15%, and also noted to have significant ventricular dystonia. His ICD was originally placed several years ago, in 2007. He had his dual chamber device. He had a Sprint Vanilla 6949 high voltage lead in place at the time, which some of you might or might not know has been recalled by the FDA. They had a high rate of fracture and inappropriate shocks in these patients. I had a recent attempt at an upgrade of the CRT system. So this is when his ICD was quote fixed, which was unsuccessful. However, a new 6935M lead was placed as his high voltage lead, and the 6949 was left in place in caps. So looking at his EKG, here's his EKG. And again, we notice that he has a wide QRS complex. This time it appears to be from pacing. This atrial pacing spike tends to occur kind of randomly, and sometimes after what might be a P wave, and sometimes it looks like it might not be capturing at all. So a little bit odd on that EKG, but definitely pacing in the ventricle. And device interrogation shows that he is pacing the ventricle nearly 100% of the time. And when they look to see what his sensing is, he has no evident ventricular underlying rhythm. He's also noted were some abnormalities in the atrial lead impedance and variations in pacing thresholds as well as sensing. So the sensing was kind of all over the place. Sometimes it was capturing, sometimes it wasn't, and the impedance was kind of moving around a lot as well. So here's his chest X-ray after his ICD was fixed. And here's his new 6935 lead, so the new high voltage lead. Here's his CAT, previous 6949, which had an SVC coil as well. And here is his right atrial lead hanging out somewhere in the top part of his IVC. So that's probably why it's kind of all over the place on interrogations, that it appears that when his ICD was quote fixed and they attempted to do the CRT upgrade, they actually dislodged his right atrial lead as well. So not only does he have AV dysynchrony, but he's also pacing the ventricle all the time. So the question comes up, what should we do with this patient? Guy's a disaster, right? And that's our first answer, this guy's a disaster. But what are we going to do to fix this guy? So, a couple things, right? We've mentioned a couple times this block HF study, which we were supposed to have the first author here today. Unfortunately, she couldn't make it. Talking about right ventricular pacing. There's been some studies done. The David trial, I believe, Dr. Dahlberg mentioned it at the beginning of his talk when he was doing Dr. Curtis's talk in the first part here. It showed that right ventricular pacing in patients with heart failure can be detrimental. So I think a couple things we can do. Number one, I think we need to get him back his AV synchrony. I don't think he's going to get any better without that. And number two, since he is going to face from the right ventricle, given that he has no escape rhythm, I think we should consider something to help him out. So while he already has a defibrillator in place, I think we should add a CRT system as well. So given that they had difficulty last time with this CRT upgrade, and they in fact dislodged his atrial lead and didn't attempt to fix it, may be suspicious that he probably has an occluded blood vessel. So our options at that point, if we do want to deliver this gap-pacing system, are either to go to the other side. We could attempt to get a wire down here and balloon this open if it is indeed closed. Or we could perform a lead extraction and remove some of those leads that he's not using anymore, dysfunctional, and then upgrade the system. So being that we have capabilities that I think providing the most definitive way of doing this, and that's with a technique called lead extraction and retained access. That's the way that we went. So here you can see remnants of a venogram. You can see that there's all this collateralization here where we shot dye into his left arm. Nothing coming down here. So this is in fact highly occluded. So we took him to the operating room and performed the lead extraction on this gentleman. So here you can see our laser sheath here progressing down the 6949 Fidelis lead, which the screw has been retracted on and has come loose from the right ventricle. And here we have fully removed the 6949 from the body. You can see it back here. We left our sheath in place in order to provide wire access through the occlusion. And then also removed the right atrial lead as well, again with the sheath, leaving the sheath in place and maintaining access. We then used a coronary sinus guide catheter, in this instance the Worley sheath, which I believe if you guys had any of Dr. Jackson's talks, he probably talked about, and delivered a coronary sinus lead into a lateral branch and added an atrial lead as well. So coming from what we started at here with the dislodged right atrial lead and two right ventricular leads. This is his new system. So now we're working right atrial lead, a new coronary sinus lead, and we left the high voltage lead in place that they placed at the second or the attempt to place a CRT system. More importantly, here's his EKG now. So you can see he's gone from that wide, complex right apical pacing morphology to a pretty excited LV and much narrower QRS complex. Not only that, but we've given you back the AV synchrony. So I think a relatively successful case. We'll see how he does long term. So why did we do this? Well, this is we've already done the only Class 1 indication on the new CRT guidelines. So this is a Class 2A indication. This is here. And you'll note that patients with a low EF and anticipated pacing greater than 40% this is a 2A indication. This is level of evidence C, meaning we don't have awesome evidence for this. It's kind of one of those things that a lot of smart people decided this is what we should do. We kind of know this. A lot of this data was extrapolated from the David trial and a couple other studies looking at some of the data from other CRT studies. And this was published before Block HF, but I think Block HF kind of verifies this as the right thing to do. So that's why we elected to upgrade a system and make it running using. So let's look at case 3A here, we'll call it, because I want to show you a second case which has a very similar theme. So this is a 54-year-old female who presents from an outside hospital with syncope. And here's her EKG. Anyone want to comment on that EKG? We've got a syncopal event. So I can comment as well. We got a little bit of a start, so we'll keep going here. So here you see some QRS complexes that are relatively slow. You also see some P waves, which appear to be marching through here. What I don't see on this side of the slide is P waves that have anything to do with QRS complexes. So I think what is going on, you have sinus rhythm up top and an escape rhythm at the bottom. Here you see some P waves that do have something to do with the QRS complex. So I think these are conducted P waves, and this is what her native QRS complex looks like. And then you go back to complete heart block again. You can see there's a P wave way over here, a ventricular basic type response that conducted the ventricular beat. But this is again an escape complex. So you have a patient with syncope and complete heart block. So she had a heart catheterization done, showed minimal coronary disease, and she also had an echo performed and showed an EF of 45%. So the question is, what do we do from here on this patient? So think about that, because we're going to move on to case 3B here, which is a 67-year-old guy with a history of coronary disease and CABG. He had a pacemaker placed in 2012 for complete heart block. He had an echo at the time of pacemaker placement, which showed an EF of 55%, so normal EF. A repeat echo now reveals an EF of 45%, and he's experiencing heart failure symptoms. Had a stress test done and showed no ischemia, and he's on appropriate medication. This has been so for a long time. Here's his EKG. So again, looks like right ventricular apical pacing. It looks like he's paced, at least on this EKG, 100% of the time. And interrogation proved that he has normal device function. He's sensing his atrium and pacing his ventricle 100% of the time. Here is his chest X-ray showing his pacemaker, an atrial lead, and a right ventricular lead. So the question here again is, how do we want to proceed at this point? And I'll be honest with you, if you look at the updated CRT guidelines, these two patients are not addressed. So this gets to Dr. Curtis's study, and we'll go over that in just a second. But in case A, the patient with complete heart block and syncope and the slightly depressed EF decides to go with a CRT system, CRT-P system. So this is a CRT-P, so a pacemaker, the right atrial lead, right ventricular lead, and coronary sinus lead. There's his or her device. And we also elected to upgrade the other guy to a CRT-P as well. So why did we do this? Well, this gets to the crux of the block HF study, and I know several people have gone over this already, so we'll be brief. But block HF looked at patients with class 1, 2, or 3 heart failure. Ejection fraction is less than or equal to 50%, so both these patients would fit in that category. Significant RV pacing anticipated. So again, one patient had already proved that he's going to pace from his RV a substantial amount of time. And the other lady has complete heart block, so at least anticipated significant RV pacing. And in the study, patients were randomly assigned to standard right ventricular pacing or biventricular pacing. And were given either a P or a D system depending on other elements of their heart disease. The primary outcome was time to death for many calls, an urgent care visit for heart failure that required intravenous therapy, or a 15% or more increase in the left ventricular and systolic volume. So what they found is that there was a significant difference in their event-free rate, which we just described, is what they considered events with biventricular pacing compared to right ventricular pacing. So again, both these patients would qualify under block HF, or at least my interpretation of block HF. Again, there's no guidelines currently with regards to this, but you're doing a fair number of these pacemakers based on block HF criteria. So one more case, which is kind of just a show and tell. We've done something that's kind of not a new idea, but it's a little bit novel to us and to other universities now, where we've used something called HIS bundle pacing. The idea of HIS bundle pacing is to place a pacing lead actually within the specialized conduction system, so they can capture the specialized conduction system, denoting that no matter how well I place a coronary sinus lead and a right ventricular lead, I can't beat what you were born with, so I can't beat the specialized conduction system for depolarization of ventricles. So placing a lead here to utilize the rest of that system in essence creating a biventricular pacing system, or at least a control mechanism by which we can make the specialized conduction system do its job. In this study, which was fairly recent, but again, just to be clear, this is not a new idea, but it's kind of something that we've recently attempted to embrace. They looked at these, they took patients and split them into two categories randomly. They were able to successfully place an in-bundle pacer in 80% of their patients, and they followed these patients for events, both heart hospitalization and all-cause mortality, and found that this bundle pacing compared to right ventricular pacing only was superior in both categories. Again, the idea is to place a balloon to take advantage of the specialized conduction system, so actually pace the specialized conduction system. And you can see here that there is a little bit of change and actually some normalization in the EKG on the bottom compared to the EKG on the top with this bundle pacing. Here's a case of one that we've done at Duke University. You can see here, again, a pacing system in a right atrial lead. And then here's our right ventricular lead, which is really high and very small. This is a lead called a select secure, which is a very tiny pacing lead. We use a special sheath to get this into place. We actually did 3 cases at Duke all on the same day, and each one of the chest X-ray dictations was the same, that the right ventricular lead was likely displaced. So I thought that was kind of humorous, but it let us know that we put it in the right spot. Here you can see it. If I can use the arrow better, you can see that it's pointed towards the septum as well. So it's up high, just on the other side of just on the atrial side of the transmitter valve, actually hooked into the specialized conduction system. Here's the interrogation from that patient, and you can see here that you can actually see his spike, so specialized conduction system spike that is being sensed before the ventricular depolarization. And more impressively, you can see here when we're doing threshold testing that we're actually capturing the beat here, but you'll notice that the beat pace is a little bit before the actual depolarization of the ventricle. And then when we've lost capturing, so beat pace not capturing anything in sense, you see that his spike is returning. And then when we beat pace again, you'll see that it's approximately the same distance before the QRS complex. Here's a 12-lead rhythm strip that I ran in this patient. So here you can see when we actually turn up the output, we capture local myocardium as well as specialized conduction system. So you can see right after the pacing spike, we have an upslope, almost like a delta wave with pre-excited patient. So instantaneous QRS complex formation, and the QRS is kind of wide. Whereas you look over here when the pacing spike is approximately 40-ish milliseconds pre-QRS, and you have a relatively narrow QRS complex. So again, another mechanism by which to potentially achieve CRT pacing, but in a different modality. So I just want to kind of show you guys that. Any questions on any of those cases or anything I can clarify? No? Okay, let me know. Appreciate it. Thanks, guys.